Afternoon to all and welcome to the post-lunch session on the glaucoma puzzle, Navigating the Uncertainty. I'm Dr. Manju from Giridhar Eye Institute, Kochi, and today we have an expert panel. I would like to welcome Dr. Sai Kumar S.J. from Giridhar Eye Institute, Kochi. Sir. ഇവിടെ ഇരിക്കാം സർ ആള് വരും. Dr. Ronnie George could not make it because of some last-minute personal emergencies. Dr. Satyan from Satyan Eye Care Hospital, Coimbatore. Dr. Abhilash Nair from Giridhar Eye Institute, Kochi. And Dr. Kiran Gopalakrishnan from Precise Specialty Eye Care, Thiruvananthapuram. We know that ocular hypertension by definition is intraocular pressure more than 21 millimeters of mercury with open angles, no evidence of structural or functional optic nerve head damage, and no other systemic causes for raised intraocular pressure. So let us begin with some case scenarios. The first case is a 64-year-old male with no significant risk factors. His intraocular pressure on DVT maximum was 30 millimeters of mercury in the right eye and 24 millimeters of mercury in the left eye. Central corneal thickness was 560. Discs were normal, fields were normal. So my question to the panel is, how do you proceed with this patient, and whether you need to do a DVT in ocular hypertensive patients, whether you need an office DVT or a 24-hour. Dr. Kiran, can you take?
Okay, so this 64-year-old patient with no systemic diseases with IOP on, it's written it's IOP on DVT.
Yeah, this is the maximum pressure, 30 millimeters in the right eye and 24. I did an office diurnal.
Okay, so the first question you wanted to ask us whether should we do a DVT on patients?
Yeah.
Doing a 24-hour DVT in the traditional method, which is to take the measurements every 3 hours, used to be done during my residency days at RP Center. I feel it is a very non-physiological way of checking the IOP. You see, imagine after 10 o'clock, you call the patient at 12 o'clock and then 2 o'clock and 5 o'clock. And these kind of measurements, first of all, is usually taken in the sitting position. Where in normal physiological state, the patient is actually lying down and sleeping. So that itself will alter the actual pressure reading. So a traditional method of DVT, I don't think is really required. But we certainly want to identify people who are what we call as spikers versus the ones who have stable IOPs. Because whatever reading of pressure you get on the first visit or 2 visits may not reflect the actual high pressures that the patient might have. So it makes sense to do kind of a mini office DVT in such cases where you are questioning whether we should treat a patient or not. So this can be done in various ways, and simple method is to call patients at multiple days at multiple times so that you get a gross idea of morning pressures and afternoon pressures and evening pressures. As far as literature is concerned, there is some evidence based on studies with the Eye Care Home 2. That is not studies based in India, but studies in the West with the Eye Care Home 2, where they have found in some post hoc analysis of ocular hypertension that if you identify spikers on the basis of the Eye Care Home 2, they are the ones who are most likely to progress. So it makes sense to have an idea of the range of pressures that a patient has. But as long as the Eye Care Home and these things are not widely available, you can kind of do mini office DVTs to get a broad idea. But generally, when you have pressures approaching 30 in a patient with relatively normal CCT, you have to understand that in the OHTS, any pressure above 30 was automatically treated. So they were, because beyond glaucoma, there are questions of vascular occlusive disease risks also with pressures beyond 30. So at these pressures, you will probably start treatment anyway, but with pressures of 24 to 27, 28, and these kind of pressures, we want to see if this is kind of stable or whether they are spikers and try to get a mini office diurnal as long as the other risk factors are not there.
Can we make a cutoff value for up to this you won't start treatment, something like that?
You're assuming that there are absolutely no risk
Yeah,
factors.
nothing. This is this patient.
Then you have to, the only option is to rely on the literature from OHTS, which basically treated everybody above 29. And I think psychologically also, I don't think anybody with pressures of 30 and all, it becomes very difficult not to treat.
So 24 can we observe, sir?
Of course,
Up
because
to 26, 27, can we keep it as?
No, I'm not aware. Maybe Satyan is aware. The odds did not mention a specific reason why this 30 was made a cutoff.
I think they were probably looking at vascular occlusion.
Yeah.
risks.
So that is a presumed risk that above 30 you have a higher risk of vascular occlusion. So in that case, would you go for a uniocular trial in this? Would you treat one eye with 30 and observe the eye with 24? Would someone think in that way?
I will just put another controversy into this. Because you have premeditated, this is an OHT. For me, it starts from the history.
Everything is normal, sir.
No, I'm just trying to.
Okay.
So when we come to a conclusion of when you have an early cataract, is the early cataract PSC? If it is a PSC, there is always a likely chance that the steroid usage or endocrine problems and other problems, which we are not really aware of. So first of all, we need to really evaluate that part of it. And when you are saying that IOP on DVT, is that you are trying to say this is the maximum IOP that you have recorded?
Yes.
That's what you are trying to say. Okay. So when you have an IOP of 30, many people still try, for the CCT part of it, I'll just come to that. Once you have the higher CCT, many people have the habit of just reducing the IOP and saying that just because of higher CCT, your IOP levels seems to be higher, but that is not the true glaucoma. But what we need to understand is the patient has glaucoma, but only thing is whether we want to really treat these patients immediately or you want to wait and treat. That is the take-home message that people have to have. Nowadays, everybody is just trying to reduce the IOP and then saying that you don't have a glaucoma. It is not that way that we have to take. So once you have an IOP of 30, if the corneal thickness of 560, this is definitely yes. Probably for the right eye, we usually have the criteria of say 25. With the risk factors, if it crosses 25, we do treat. Definitely yes. But if you don't have the risk factors, if the IOP is around 30, then it is better to treat with a 30. 24, possibly yes, we can still wait without any much of a change. But this is all, I can't say this is absolutely, this is how we have to go. This is for this patient, for this eye, we can look at it. But even I may change this over a period of time, again, by looking at the patient, whether everything is coming back normal. There are the hidden things like a hypertensives. So all these things needs to be taken into consideration.
So if you are planning for an observation, how frequently you follow up these patients?
Okay. Again, that is only, like our own personal things, but with some studies, maybe 4 to 6 months on an average, with a close monitoring, we can really look at it.
Yeah. One thing I wanted to say about the follow-ups is that, especially for ocular hypertension, if you base your results on the OHTS, first of all, this value of 24,
The other one,
that itself you have to understand that the OHTS only took patients with pressures greater than 24 as ocular hypertension. So, sometimes the general trend is to treat anybody with 22, 23. That should be totally, not be the case, because even to be classified as ocular hypertension, it needed to be above 24. And as far as the follow-up and the evaluation is concerned, in ocular hypertension especially, you have to understand that in the initial trial results at 7 years, when it was published, the phase 1 results, the conversion to glaucoma was not only on the basis of visual field. It was also on the basis of masked reading of the optic disc photographs. So either of these, so the patients who converted to glaucoma were either visual field positive glaucoma conversion, or they could be disc POAGs, which means the change was there in the disc. Sometimes. But the point I wanted to make sure is that nearly 50% of the patients who developed structural changes in the optic discs on stereo photographs did not have a corresponding visual field loss, which means it is very important in these cases to follow patients structurally also, and not just on the basis of visual fields. Whether a structural change needs to be treated or not is a different question, but there is clear evidence that in ocular hypertension, even in 20-year results, the 20-year results were published of OHTS about a few years back. It's very important data to consider because we hardly ever have any landmark trials with 20-year data. OHTS published their 20-year data. There have been at least multiple papers on post hoc analysis also. All of them clearly show that there could be pre-perimetric changes in a certain set of patients. And therefore, it's important to basically evaluate both structurally and functionally.
That throws a lot of other things again, like say patient aged about say 75 years, 80 years.
Yeah, I'm coming
Is that
into
we are
that.
really going to treat them?
Yes, sir.
So there are a lot of the target IOP chart, if you can remember, then we can really
That
follow
is an interesting thing because if you look at the risk factors for OHTS progression, one of the risk factors mentioned is age.
Age, yeah.
That
Here,
I'm
if you have a
coming into.
higher age, you would actually be at the higher risk of progression. But from a practical perspective, their life expectancy is also going to be not that important. So,
So I think
age
can we have a consensus that these sort of patients we would check pressures every 4 months, and at the end of 1 year we'll do a field as well as an RNFL OCT.
Yeah.
Can we generally?
year, once in a year is fair enough.
Yeah. So
But initially, I think, one of the
understand.
things you find in multiple trials, not just across ocular hypertension, but across other kinds of glaucoma is, there are always two categories of patients, the rapid progressors and the slow progressors. So initially, the evaluation should be in the first couple of years slightly more frequent because when you see a patient for the first time, you never know which category the patient is going to be.
Yeah.
So initially, maybe it makes sense to check every 4 to 6 months. And once you, at the end of 2 years, you kind of, understand that this patient is likely to be a slow progressor, then a yearly evaluation with all the
okay.
paraphernalia might
So
be.
the second case was 24, everything was same, but 24 and 23, I think we will just observe for this case with a frequent follow-up. So if the pressures are 24, 23 and some risk factors like family history of glaucoma and thin cornea, so then would you consider treating with multiple risk factors with a pressure of 24 and 23?
See, in general, yes. But again, considering the other findings like age group, somebody
Age is the same, sir. Everything same, but only added
for
thing
this
is
patient, if it is 23, 24,
With
even
a
with
thin
the risk
cornea.
with thin cornea, I still, for the first 2 visits or so, I will still observe without
okay.
23, 24 I am talking about, not the 30s.
Okay.
One thing that is not mentioned in literature, which I kind of feel needs to be mentioned is, like I sit in a Trivandrum hospital and see patients. I have a lot more time. And I go to the peripheral branches, and sometimes it's not just a question of urban versus rural, but the level of comprehension of patients also varies. So as Sir said correctly, these kind of patients with 23, 24, slightly thin corneas, that itself is debatable whether 490 is thin for the Indian eyes. But still, thin corneas and family history, people who are really, who have an understanding of and comprehension of what we are trying to say. Okay, like, if we treat you, you have if you don't treat you, you have a certain risk of conversion to glaucoma. Yeah. If we treat you, we are reducing that risk. We are not eliminating that risk because one of the important data from the OHTS 20-year results is if you don't treat, 50% will convert to glaucoma. And if you treat, it will come down to 40%, but it will still 40% will convert to some extent to glaucoma. So you are not eliminating the risk, you are only reducing the risk. If patients also kind of understand these things during your discussion, then it makes sense to observe, even in such patients. But, if that level of comprehension is not there, maybe we might be better off treating.
Yeah, in these patients, especially when you have the family history, it will be really interesting to see how mother or the father or the siblings had the progression happening. That will be really kind of an eye-opener. If you really see that those who had in the family, the disc will be similar in appearance. Father and son having, the disc will be the same. And if you can really observe the progression of the father, then it is easier for you to treat this child or not to treat. Not
I
child,
think
but
this is one point which I learned from Satyan, because the last Drishti also he mentioned this. To know the rate of progression of the family is very important. So after that 1 year, last Drishti, I had at least 2 patients with similar thing, but one of the parents has gone blind due to glaucoma. So I think in that situations, you should not stick by the rule book and think that no, he doesn't fit into OHT, so I won't read. So I think these are points that you have to take into consideration. So an individualistic approach has to be there.
So thin cornea, the disc is like this. This suspect with the thin cornea, pressures of 24, 23, I think still we can observe for the follow-up, no sir? With
this
the
is normal.
Yeah, no, this, I mean, the CDR is large CDR, we'll observe with a follow-up. Yeah, so this is the pooled data from OHTS and EGP prediction model where they have considered a few risk factors and they have given some point system. And then you have to add on the points, and if the values are less than 4, it is 5-year risk of progression is less than 4%. It is, this was,
Yeah. See, the prediction model was based on the original phase 1. Yeah. So the predictive model in the OHTS website still only includes those 5. You notice that family history is not there.
it's
because
not there.
it was not included in the initial thing. Now, because after the 20-year results were published, there have been post hoc analysis. So, for example, there are at least 2 or 3 papers which actually tells you that the genetic testing through PRS, polygenic risk score. So that shows, clearly shows in the post hoc analysis that people with high PRS will tend to progress faster. And more importantly, they said that people with low PRS do not progress. So that will give these kind of post hoc analysis there, but the original risk model still remains.
So can we make the key take-home messages as like this? Multiple or high risk factors may need treatment. Low risk factors or less factors may need frequent follow-up to detect the earliest sign of progression to initiate treatment. However, every patient with ocular hypertension need lifelong regular follow-up regardless of treatment. Is this okay?
Yeah. In general.
Sir?
In general.
In general. Yeah.
There
So
are a lot of ifs and buts are there in every given patient.
So the next is primary angle closure disease. We all know that pupillary block is the mechanism and YACPI is the first line of management in all cases of PAC, PACG and acute angle closure. But in PACS, there are certain indications for YACPI. But when there is a coexisting cataract with primary angle closure, how do we proceed? So the first case scenario is a 60-year-old male with no family history of glaucoma. The BCVA in the right eye is 624N8 and the left eye is 66N6. Anterior segment showed SIMC in the right eye, very early lens changes in the left eye. The intraocular pressure is 19 in the right eye and 18 in the left eye. Gonio showed occludable angles in both eyes, no PAS. The disc is healthy and it's a case of SIMC with primary angle closure suspect. So how do you proceed with this patient? Whether the options here are a YACPI, direct cataracts. So do you want to do a YACPI or direct cataract surgery or YACPI followed by a cataract surgery in the right eye?
I think YACPI in the right eye with cataract surgery. After that, cataract surgery.
Left eye, you don't need a cataract, no? It's only a YACPI.
In the right eye.
Right eye, all of you think that we need a YACPI before dilatation, or can you directly do a cataract in PACS? Never do a YACPI.
Once I see the cataract, I never do a PI. You don't have to really dilate preoperatively in all these cases. Intraoperatively, after incision also, you put 1 drop of either Oculan or the phenylephrine combination, pinocaine. It just beautifully dilates. You don't have to really worry about whether you are going.
I mean, you will not put dilating drops and patient come into the OT. Directly on table, you will dilate.
It is not that angle closure. Every patient has a pupillary block mechanism. Some people have only an angle closure in the peripheral PIS formation, not the pupillary block. Pupillary block, you will tend to see that once you have a very thick lens or the contour, if you can really understand the contour, then those are the cases where you will be little tensed whether if I dilate, whether these patients are going to go for a pupillary block. But in majority of the cases, you will probably in my lifetime of this 35 years in ophthalmology, I would have seen probably 5 or 10 acute angle closures totally. So the acute angle closures are not that very common. It is not that uncommon also, but you don't have to really too much worry in this kind of cases where even if you see 360 thing, but how is the contour makes really a lot of sense.
So do you do an ASOCT or pre-op to see your
in your
lens?
regular A scan, you will know that how much
Thickness
is
of
your
the
lens
lens.
thickness, and also in your slit lamp, you will know how is the contour of the iris. So this will help you whether you want to really go for a PI or not. But if the cataract is there, even if the contour is not good, I will not do a PI. I will directly go for a cataract surgery, and intraoperatively you can dilate the pupil. That will be fine. No need to do a surgical, laser PI.
Sai sir, what is your...
Which one? I used to do PI in every case. 15
I think I
years.
agree with Dr. Satyan because most of these patients, the acute attack occurs not in a fully dilated stage. Many times it occurs when the pupil comes back and becomes mid-dilated. So even if you dilate these sort of eyes preoperatively when they come to the OT, and once you finish the surgery and debulk that entire area, actually nothing happens. So my question is, suppose you have access to an ASOCT. Okay, and you have found out there is a significant lens vault with everything else normal. Would you stick to the same pattern or you won't make something?
Absolutely yes. I will not change. Because earlier days I used to do regularly, every patient used to be PI. But past 15 years I have not done a PI for all these cases. You straight away take the patient in. The moment you put the anterior chamber entry, you are just avoiding everything, every possible IOP spikes. I don't think, at least I have not seen anyone.
Sir, the issue is not pre-op in the OT on the day. In this case, here you see the vision is 624 N8 and the occludability is there, but you can still see the Schwalbe's line. And I assume the configuration is not scary enough. But imagine if you have a patient with a very scary looking angle where you can't see the Schwalbe's line, the convexity is so much, and the pupil is on the myotic side, and then you have a 636 vision and you can't see the disc at all. So in such case, a pre-op evaluation of the disc status is required, and then we will need to dilate. So in such cases, would you take the risk of dilating such patients without PI or not? That is
That is exactly what I was saying. If I come to know that the disc, everything is already normal, IOP is normal, disc is normal, I will still not go for dilatation or PA also. PA gives me more problem in the intraoperatively than just going directly in for the cataract surgery alone. Because probably after you start doing all the angle closures, you will understand how the PA really disturbs you when you're doing the surgery than without the PA. But it doesn't mean that you should not be doing a PA. But when there is no cataract, when there is an indication, and if you feel you are not a competent surgeon, very well go for a PA and then take it up. I am talking about reasonably the one who knows to do a cataract surgery comfortably. They need not go for a PA in every given patient like this. But if you feel uncomfortable, nothing wrong in going in for a precautionary peripheral eye dot. Nothing wrong in that.
Absolutely agree. So there's no harm in doing a PI. That is not the take-home message here. If you're comfortable, if you want to do a PI to be on the safer side, please do. But it's not mandatory. If you're going to operate on the cataract, the patient is willing for cataract surgery in the coming few weeks, there's no point or not mandatory to do a PI. And one more thing is that you can, we have an access to the Optos, which gives you a beautiful peripheral view in an undilated pupil. So if you have access, you have seen the retinal periphery well without dilatation, you have seen the disc well without dilatation, and provided you know that all these are normal, Again, PI is not mandate. But if you want to do, you can do, but you can manage even without that.
So if it is a primary angle closure, as in the next case, pressure is high and there are synechia more than 180 degree, even then disc is still healthy. It's a primary angle closure. So even then you go for a direct cataract surgery, or in this case do a PI and cataract followed by cataract.
Yes, cataract here. obviously,
Direct
because-
cataract.
Because cataract is there.
PA for economics, yes, but
No,
not
because see, the broad point here is that the idea of doing a PI is to open up the angles. We are getting much higher degrees of angle opening with the cataract surgery. This is well documented. The degree of opening which you can get by PI is actually quite minuscule. It's there, it's significant enough. But cataract surgery changes the angle configuration so broadly that the effect is 10 times PI. I'm just exaggerating a little bit, but
I will put it in another way. Suppose this, almost full synechia was there, and you're going ahead with a cataract surgery. Are you going to do just a cataract surgery, or you want? Yeah.
So this is only a primary angle closure, and the next case is vision is 636 N12 in the right eye and 612 N6 in the left eye. The pressure is 30 millimeters of mercury with 3 anti-glaucoma medications, and your target is around 10 to 12. Closed angle with PIS more than 180 degree, and there is a advanced damage in the right eye. Left eye, again cataract is there, but the IOP is controlled with 2 AGMs, and synechia is less than 180, and there is an early damage. So it is SIMC with PACG. So options, whether trabeculectomy, cataract surgery or combined surgery.
No, in the right eye, definitely you have to do cataract surgery. You have to do cataract surgery anyway, but I think I'd combine it with the
Combine
trab
surgery.
also. Because,
Abhilash, is it that anyway you are doing cataract surgery, you want
No,
to do a combined surgery, or you want
no,
to do
combined
a
surgery. Combined surgery, yes.
Yeah,
Because
because-
vision is also like
See,
compromised.
on 3 AGMs, I think this is a very clear-cut
Yeah.
thing. 3 AGMs, 30 IOP, you're expecting to be around 10 to 12. It's very clear.
Combined.
here
What
60
about
to
the left eye, sir? Kiran?
Yeah, in the left eye, you can generally one of the things you can do is what is your target and what is the current pressure. So here you only want to have a reduction of 5 millimeters of mercury. That is hardly about 20-25%. We know from a lot of meta-analysis, on an average, you can expect around 30% reduction in angle closure glaucomas on cataract surgery alone. So it is very likely that in the left eye, after cataract surgery alone, with 2 medications, the patient's pressure is likely to fall down to the target pressure. So as long as the patient is okay with continuing with 2 medications, this thing, that means you can just do a cataract surgery. Now, if you want to take off the medications also, it will be interesting whether you would want to combine it with an excisional goniotomy.
Yeah, I think
As long
yes.
as the angles are.
What I wanted to say is already told.
Yeah.
For
So
the
that
left
is
eye, if you have done a combined surgery in the right eye, I wouldn't be continuing the left eye with medications. I would rather look at how I can be completely take off the medications for him. So I would go with the mix with the cataract.
cataract.
That gives a definitely but whether that is going to eliminate completely the drops, we'll have to see. Most likely there is a possibility that we might eliminate the drops, provided that you have done a proper mix.
Yeah. Generally, I
Because
think
mix in an angle closure, little bit of a controversy is there at this momentum, because we keep talking about the mix in an open angle glaucomas. In the angle closure, it does work, but just for the audience sake, as of now, we are not trying to actively promote the mix for all the angle closures as well. Removing the cataractous lens definitely helps in reducing the intraocular pressure, but if we can really identify and do a mix in this properly, does reduce the number of post-operative anti-glaucoma medications.
So would you consider a trab with cataract? Cataract with mix is okay. Would you consider a trab with cataract in this case, left eye?
If you don't know how to do a mix, yes.
And if you can do traps like him. But otherwise, in that eye, phaco trap is quite, aggressive.
Again, it all depends upon how comfortable each surgeon is in performing the surgery. So if you feel you are not comfortable in doing the mix and your results are not comfortable, go with the trap with phaco, nothing wrong in that. Because you want to take off completely the medications off from the patients. Binocular is always better than continuing with one eye medication. It may not really make a good sense actually.
All medications with your combined surgery. That is also there, no?
Sir, which mixed procedure will you do in an angle closure with 180-degree PAS?
The remaining 180.
I still go with either KDB or with my bank. So either one of these procedures, because I am not as rich as many other surgeons. So I am still sticking on because I am not still very comfortable in just going in for an eye stent. For that price, am I going to give them really completely off the medications is in an angle closure at least. So for this eye stent, I won't go. I will probably go with the incisional like KDB or a bank.
Excisional goniotomy makes sense here because the only problem is like which angles are open and which angles are closed because we generally attack the nasal angle. If the nasal angle is open, it makes sense because you don't have to do much manipulation. I've been doing temporal goniotomies also for some time now based on my guru's advice. So that is also possible. Wherever it is open, it is better to do. Of course, you can release the synechiae and then do it. But then more often than not, you'll have to put the patient on pylo for a reasonably long time. And so wherever the angle is open, I think.
So the next case is the same as in the previous case, the right eye, but the cataract is early and the nerve is advanced with the split fixation. So very advanced glaucomatous damage with an early cataract. So in this case also, would you go with the combined or trabeculectomy, filtering surgery alone?
So what makes you not to go for a combined? So your focus is on the split fixation. The patient might go for a blind eye, right?
Success rate of combined might be less if you do, less compared to the filtering surgery alone or cataract alone. The literature has says reports also like that.
I think what he's trying to say is phaco trap versus trap alone. In generally, traps alone tend to give lower target pressures. When you combine phaco traps, generally the pressures seem to hover around the 15, 16 mark rather than the 10, 12 mark.
You want to do trap first and then later on take up the cataract?
That's what
No,
I'm
that
asking,
is
whether
a very bad idea. When trap once you do, then the next 6 months or 1 year, cataract will fill that trap very easily. So the question really in such cases is, if the lens fault is very high and you want to avoid a combined surgery because you want the target pressure to be lower, should you do a cataract surgery first, wait for 4 to 6 weeks and then do trap as a sequential surgery, or whether we should go for a combined surgery in the one sitting itself. But trap followed by phaco is generally a very bad idea.
Yeah, it's not a good idea. No, if you want to do, you do the cataract and then do the trap, that is fair enough. But if you're going to do the trap first and then going to do the cataract, then trap will go for a failure. Okay, so that is not a good idea to do.
But
Rather, I would go for
There are scenarios like, the cornea is not very good, raised IOP, DM folds following an acute attack, where you want. No, I'm just saying. So I think there are scenarios where you would like to do a trap first and get the pressures under control, get your cornea better.
No, that is, I completely agree on that.
Because I do quite a lot of, patients who have been trapped by Manju and I do the cataract portion. But as you said, if you look at the failure rates of the blebs long term, probably it's better to do the cataract first and then a trap.
Yeah, you can do a cataract, but you'll have to probably delay it as much as physically possible. Because anything within the 6 months is going to cause a bleb failure.
See, the problem in post-trap cataract surgeries are how much of the inflammation that you have going to create during the surgery because of the synicase and other things, and viscoelastics, amount of viscoelastic that you use, manipulations which you do, that will cause slowly the bleb failure. It is not that immediate bleb failure you see. The bleb failure happens over a period of 3 to 5 years. It doesn't happen overnight. So that is where the problem comes. Even the functional bleb will go for a failure. But you do the cataract first, then you can do the trap later. That
But
the
this is-
survival.
Whatever,
IOP is
whatever you
not
lose in the bleb, you actually gain by removing the cataract. The pressures remain pretty much the same. I mean, I don't have any long data or anything. But whatever cataracts we have done late, 6 months, 8 months, 1 year following traps, I mean, a huge number of failures we have not noticed. I don't know the reason.
Usually they do. It all depends upon how big the bleb was. If you have already noticed a little bit of a scar tissue formation in the bleb, those blebs will surely go for a failure. Those with a huge, very leaky blebs, it may survive. Like you have done a trap now, then you're going to do the cataract, say after 5 years, and the bleb was pakka functional. These blebs may survive, but otherwise, usually they go for a quick failure.
So the next is normal tension glaucoma. By definition, it is glaucomatous optic nerve changes with RNFL loss and functional visual field loss with no measured elevation of IOP on DVT. So it's a diagnosis of exclusion. So the first case scenario is a 51-year-old female with diabetes and thyroid dysfunction. The best corrected visual acuity is 6.6 N6. Anterior segment is clear lens. Intraocular pressure on DVT is 15 to 18 in the right eye and 15 to 17 in the left eye. Open angles, and the central corneal thickness is 540. The right eye is showing bipolar notch with RNFL defect both superior and inferior, and the left eye has a superior damage. The field is showing advanced damage in both eyes with split fixation. And my question to the panel is, how do you proceed? What investigations you would advise in a case of NTG before starting the treatment, and what would be your... No, suppose since the pressure, it can be an open angle. I mean, maybe we are missing the spike because DVT it is less than 20, so I put it as NTG. Sir?
The patient is not even glaucoma, I'm saying. Can you just go back? The right eye, why you are trying to say it is glaucoma? Just, I want you to really look at the disc shape. Look at the disc shape. The cup is corresponding to the disc shape. And I really don't know whether there is a real NFL loss because the picture is not good enough for me to
There
understand.
is, sir.
There seems to be RNFL loss inferior, but the defects in the
Superior and inferior
and
RNA.
then
It is
just
clear in this actually.
In the
in
right
my...
eye, if you really look at the field defect, it is same in the inferior. Okay, this is this side. Okay.
right eye
Yeah, I got
superior
confused
itself.
with this. Okay, then it is okay. I mean, I was just thinking at the right was on this
Oh.
side. Okay, so it looks like there is a definite damage. So your question is now.
What are the in a case of NTG, how do you proceed? What all investigations would you do? Sai, sir.
No, I want Abhilash to,
Okay.
because we are overdoing actually.
No, investigations basically systemic investigations. Whether this patient is hypotensive, systemic hypotension, whether there is a nighttime
Nocturnal dip.
dip or taking antihypertensives at night, then sleep apnea. I would like to look into. Now it's difficult to measure the optic nerve perfusion as such, but if that is possible, like Doppler studies or something, carotid perfusion, cardiovascular anomalies, migraine, which probably ladies in this age group are more prone for, vasospastic problems. Those sort of evaluation I'd like to do.
So
Medical checkup.
when we are diagnosing it, you straight away go ahead with all these investigations, or first you do few and then if all are negative or showing a progression, will you go ahead with further investigations?
No, she's already having significant field defects. So
Yeah, no,
rather you'll
the
have to do
systemic evaluation.
systemic
I want.
evaluation. I'd like to send early enough, not wait for something to happen. Whether they come back or not, also we won't know.
About carotid Doppler and imaging or cardiovascular assessment, whether we have to do all those things.
I'd like to do a physician workup the patient and then decide whether I'd like to leave it to a cardiologist or like be suffice with the physician workup.
Satyan
That's
sir,
what
anything
I'd
to
like
add?
to.
Kiran.
Sir has some spicy stuff to say. He is actually waiting for everybody else to. Okay. Actually, I don't investigate very aggressively. Whenever I see an NTG for the first time, I simply put the patient on the most powerful IOP lowering agent, which will cause the least IOP fluctuation, which would be prostaglandin analogs, and simply follow up the patient. I will make a note of migraine, sleep apnea, and Raynaud's in the form of history. Whether they have cold hands and feet. I have cold hands and feet. So I make a point on the chart, migraine, the triad of migraine, sleep apnea, and Raynaud's. And obviously, here patients are not, they would have some sort of, the patients are usually already on some antihypertensive medications. Again, I am not going to send the patient for a Holter monitoring for 24 hours, and these are all not done. I think for me, I don't do any of this in the first chance. Of course, if you are, in spite of adding medications and there is some evidence of progression, that is when you start to behave more aggressively, sending patients for very aggressive evaluations and all. But otherwise, it's just based on a history and just keeping it a note of things, but starting the patient on treatment, because we know that NTG patients do very well with medications. Only about 12% on average progress once you start treating them over the next 6 to 7 years. 65% do not progress anyway. So I wouldn't very aggressively go for investigations. But keep a note of these things and go aggressively once there is some evidence of progression.
So if there is progression, what all things you advise? Systemic?
If there is an evidence of progression, I generally then start to specifically take history for example, is there a nighttime dose of hypertensive? I will send the patient. I have only sent 2 patients till now, in the last 15 years, to a cardiologist for a 24-hour Holter monitoring. And in one of those patients, the cardiologist decided to, change the medication to morning. But these days, most people do give morning doses of antihypertensives. So only in such situations, or if the patient is having, history of sleep apnea on the basis of whatever you can gauge from it. Again, I am not 100% sure because I think Dr. Satyan was also saying last time in one of the panel discussions about whether sleep apnea treatment has a positive impact on glaucoma. I feel the literature is very questionable on that, but again, that's a moot point because if somebody has sleep apnea and significant enough, he will have to be on CPAP to avoid cardiac risks. So whether it has a beneficial effect on glaucoma is secondary. But those histories need to be more aggressively pursued. That's all.
It's quite interesting actually. Whether to do all the investigations to begin with, again, there's a deep history will really help to, take reasonable things. But again, the controversy is on treating the sleep apnea, whether that has a good or bad. So some literature says that once you give the CPAP, aggressive CPAP, which is kind of opposite way. So the pressures goes up then coming down. So that is also kind of things. And if you really look at the ambulatory BP, so I was just checking my ambulatory BP. The nighttime dip is like, if it goes to like a 50 diastole, how much does it really cause a damage? So I was just going to the American classifications. The 50 diastole is kind of normal. So how low that it has to go for us to have the real effect on the NTG case, I really don't know. Is it the 30 or 20? I might feel the patient is already dead, like 20, 30 and all. So it's quite controversial on the carotid Dopplers as well as on the sleep apneas. and the nighttime lowering of the intraocular pressures, I really don't know at this point in time. But as of today, with the available literatures, these things needs to be taken care. But whether it really helps us in treating or modifying the treatment is, I don't know. I wish I know that clearly, but as of
I think that's a very, very valid point that both Kiran and Satyan have said. It's good to know the history of sleep apnea, but how much it impacts your glaucoma treatment? Are you going to treat just the sleep apnea and not treat the glaucoma? Obviously, you're not going to. With this sort of field defect, even just without any evidence, you can say, I would like to have a target pressure of 10 or 12. And you aim for that and you start whatever medications you need for that and monitor progression. The other things, as he said, are just factors that, probably tell us some other risk factor like Raynaud's and sleep apnea and things like that. So I think we're too much emphasizing on these sort of things.
Yeah, few things
We should know that. It's not that we shouldn't know, but the primary treatment part of your glaucoma, I think pretty much remains the same.
The sleep apnea part treatment will be required for preventing cardiac
Yes,
issues.
absolutely.
But the thing is, like in a few conferences, normally what happens is there are a couple of case presentations where, the patient is identified with normal tension glaucoma. There is history of sleep apnea. I have sent the patient for sleep apnea, sleep study. Now patient has been put on CPAP. Now over the last 2 years, the fields have been remaining. Those are anecdotal evidences
that
because
is-
most of the normal tension glaucomas do not progress anyway. So that will not be an indication to push patients into such kind of treatments.
A few things are quite interesting in the NTG is taking a good history again, especially on the yoga.
Yeah.
Breath holding exercises and what is that upside down one? The
Shirshasana.
Shirshasana, Sarva.
Sirasasana definitely has a progression that we have clearly noticed. So those kind of things like a bench press or Sirasasanas, breath holding exercises may definitely have an impact on this. But in other ways, like a carotid Doppler study is just looking at, closure or unless there is a flow impedance, it is not going to make any sense to us. So we have to be a little careful about whenever we are, but the treatment part of it, once you see the progression, medications are going to be almost the same, like how we treat with the
No, the other patient was 50s year, but this patient is 85, the second. So this patient, would you want to treat or wait for the progression? The same picture, but only difference is elderly patient.
Yeah, we want him to have one cardiac arrest so that we don't have to treat him.
So
Yeah, but
This
again, when you have a split fixation and all,
Better to start
why
with-
don't you simply put him on one medication at night? He is already likely to be on multiple tablets. Let him put one drop. It will be safer for us and for the patient.
And if the patient was having a history of any vascular pathology, then would you attribute it to that or would you want to start treatment?
Even if we attribute it to that, the fact is, see, what data we have on normal tension glaucoma is based on the CNTGS data. So whether the patient had a post CABG or post stroke or anything is kind of irrelevant as far as the treatment part is concerned. Let them take care of the CABG and the stroke and the MI, whatever is from the cardiology side. Let us
Better
treat
to
the
start
glaucoma.
treatment.
And like Kiran said, PG analog at night. One
Okay.
drop at night, no systemic problems involved. Nobody is going to object. And
Okay.
for whatever it is, worth, you better start it.
Yes.
Don't load an 85-year-old person with, multiple medications which can impact his systemic health and things like that.
So that
See.
patient had a high teens on DVT. So if the DVT is only 10 to 12,
I'll just answer that one more part
Yeah.
of it is when you have a triple vessel disease and the patient has to go for a cardiac surgery, those kind of patients, definitely the NTG progression becomes very slow post cardiac surgery, CABG or whatever.
Huh.
So that is one thing which we have clearly seen in our practice.
so would you start treatment or not? Anyway, you will start
No,
treatment.
treatment we do give, but the progression part
Will
of
be
it, I'm
less.
saying,
Okay.
definitely they have a significant change in post CABG.
Okay.
So when you have an IOP of 10 to 12, for me, whatever medications you are going to give, is it going to be effective?
That's
None of the
what-
medication is going to be effective
Yeah.
when the But for the sake of giving, sometimes we do give, which may not work. So for these cases, again, yes, already DVT has been done. So the range is only 10 to 12. I would really see how much is the rate of progression. If
Yeah.
it is a very slow progression, I would still see whether the progression is true progression or a pseudo progression. I wouldn't go on treating 51 years, but first of all, if it is
No,
51
this is
years,
51 years, sir.
51 years, and if you see there's a definitely a NTG, I would still go for a ruling out other possible causes.
What
Yeah.
is the level of field loss in this?
This is everything is the same.
So
Okay.
she's
Only
You are
trying to attribute
she's
the
trying
same
different
findings
different
for
age
all.
scenarios.
Yeah. If it is that age, what would you do? Something like that. But I mean, if it was that age group,
There are
and that,
patients on bimetoprost, at least I have at least 10, 12 who have single digit IOPs. So
51 with a 10 to 12, I would still rule out the pituitaries than diagnosing this as just straightforward NTGs. Because all the NFL laws, not necessarily it has to be only glaucomatous.
so can we make
That
it
is
like
one, sir, that is a very interesting point. Actually, recently I had to give a lecture on optic neuropathies and I wanted, looking at the literature, so the famous Dr. I.K. Ahmed in 2000, they published a paper. What they did was all the NTGs, first 75 patients prospectively, classical NTGs, they did a neuroimaging. All the 75 patients prospectively, 4 of them had pituitary tumors.
Why I am telling you, Kiran, is I started becoming little depressed now. Many of my NTGs had become more of a multiple sclerosis, thyroid disorders, pituitary adenomas, which we have missed out. So we have very limited knowledge. With the limited knowledge, we are trying to say this is NTG. But truthfully speaking, we have to go much, much beyond. And the OCT really helps then the visual fields, the pattern of NFL loss. Even if you have a NFL loss starting from the disc margin, if it is not towards the macula and much drifted away from the macula, it is mostly the stroke that you are dealing with.
I heard actually one more topic, but I think it's time up, so we'll stop
I'm
it
relieved
here.
of my myopia topic.
Yeah.
Thank you. Thank you. Wonderful
Okay.
discussion. I think we can keep discussing many more things, and this is the way which we really wanted to go with the glaucoma sessions. And I'm really happy all the glaucoma sessions were oriented towards more of a practical learning in KSOS. I really want to congratulate all the speakers as well as those who are conducting the ICs. And
that's a big compliment coming from the president of the GSI.
yeah. Well, actually, it is nice because we don't want to really see the just presentations and go on. Thank you all. And it is really wonderful to see the crowd actually for the glaucoma session. Post lunch,